Hi, good afternoon or morning, depending on what coast you're on. So we'll do a lightning round a little bit earlier than what I initially planned. So I'm going to give people a few minutes to see if they get the notifications so that they can join in with us. So hang tight and we'll get started. So again, if you're watching the recording, just fast forward maybe a few minutes. Okay? We'll wait and see if anyone joins in. This is a bit earlier than I planned on doing it. Right, if you're joining us, just type down below, say hi, where you're from, when you're taking your boards. All right, if you're just now joining us, you can type your name down there and say hi and let me know when you're taking your boards. Hello. Say hi down in the comment section, guys, if you're just joining in. Wait a couple more minutes for people to get here. Hi, Rebecca. Hello. This isn't the time I originally planned on doing this, so we may have very few viewers today, but as long as I got a couple, that'll make it worth it, and then people can watch the recordings later. Okay. So if I can get to 5 people, we'll get going. Right now, I think we're at 2 viewers. Hi, Naomi. That's my grandmother's name, Naomi. Hi, Marion. Good to see you again. All right, well, let's get started and see who joins in as we go. All right, so we're going to do practice questions today from the Leak book. So we'll go through and I'll ask you the questions, give you the options. Then you guys will type in the answer that you think is correct. And then I'll give you the correct answer and we'll go over extra material about the topic, or we will talk about the rationale, test taking tips, anything like that. Okay, so let's get started. We'll go as long as my daughter's asleep. Once she wakes up, we'll call it quits, okay? All right. A 75-year-old patient has a history of benign prostatic hyperplasia. Which of the following clinical findings is expected during the prostatic exam of this patient? So I always recommend when you're doing practice questions or when you're taking the board examinations that you kind of pause after you read the question, kind of think about what you would want the answer to be, and then look at the options. And you'll find often, if you are familiar with the topic, the answer that you kind of chose would actually be there. So you think of the BPH prostate, kind of think about what that should feel like, and then we'll look at our options. Okay, so A, prostate feels rubbery and uniformly enlarged. B, prostate feels boggy and warm. C, prostate feels hard and indurated. Or D, presence of tender nodules on the lateral edge of the gland. So A, prostate feels rubbery and uniformly enlarged. B, prostate feels boggy and warm. C, prostate feels hard and indurated. D, presence of tender nodules on the lateral edge of the gland. So just type in which one you think. Give everyone a couple of seconds. Good. Rebecca, you got it right. Any other guesses? Anyone else want to guess? Yep, the answer for this one would be A. The prostate feels rubbery and uniformly enlarged. Rubbery and uniformly enlarged. The boggy and warm is usually associated with prostatitis. Okay. And then the nodules, of course, that's what we kind of associate with cancer. All right. 517, if you're in the leak book and you're curious where I'm coming from, a 55-year-old woman brings her mother, who is 82 years of age, to the emergency department of a local hospital. She reports she found her mother on the floor when she checked on her that morning. Her mother was awake and oriented but needed help getting up. Her mother states that she thinks she passed out. She is being evaluated by a physician who orders an EKG and an X-ray of both hips. Regarding laboratory testing, which of the following tests is important to perform initially? Okay, so a lot of information in there. Again, board questions are often scenario-based, so it gives us a ton of information, and then we have to decide whether this is pertinent. So we go back through it. We've got an older woman, passed out with loss of consciousness, alert and oriented now, is being seen, already has an EKG and an X-ray ordered. What else should we do initially? A, urinalysis, B, serum electrolytes, C, blood glucose, or D, hemoglobin and hematocrit. Regarding laboratory testing, which of the following tests is important to perform initially? Urinalysis, serum electrolytes, blood glucose, hemoglobin, and hematocrit. Which one of those? Hi, Valmorez. I'll give a couple minutes for everyone to kind of guess on that one. Let's see what we got. All right. So only one's gotten it right so far. So try again, Marion and Rebecca. Let's think again about the question. It says, I think to me the keyword here is initially. What are we looking for initially? What has to be figured out right away? All right, so the correct answer to this one would actually be the blood sugar, because we need to check the blood sugar as close to the incident as possible, because it will be more reflective of the patient's actual blood sugar during the incident. So your analysis we can check later on. We can check the H&H later on, maybe see if they have some anemia. We can check their electrolytes to see if their potassium or magnesium's off. But initially, I think that's what it's trying to get you to realize there, is when it's like, what's the first thing you got to do of these lab tests? You got to check their blood glucose as soon as possible, as close to the incident as possible, because it could have been just some low blood sugar. Okay, so all of them do make sense. You would eventually run all four of the tests, but I think what the question is asking for is which one do you have to do right away. All right. All the following clinical signs and symptoms are seen early in testicular torsion, except. All the following clinical signs and symptoms are seen early in testicular torsion, except. So this is a negative stem question. Okay, so everything, we're looking for the one that occurs, maybe doesn't occur, or maybe occurs later. All right, A, nausea and vomiting. B, absence of the cremasteric reflex. C, affected testicle is elevated compared with the normal testicle. Or D, affected testicle is swollen and feel cold to touch. So which one of those is not seen in early testicular torsion? Not seen in early testicular torsion. Nausea and vomiting, absence of the cremasteric reflex, affected testicle is elevated compared with the normal testicle, or affected testicle is swollen and feels cold to touch. Hi, Renee. Glad to see you here. Good, good, good. Mm-hmm. Hi, Glenda. Try again. Good, Rebecca. Good, Marion. Yep, good, Renee. Excellent. Yep, so the correct answer to this one is D, affected testicle is swollen and feels cold to touch. That happens the further you get into testicular torsion. Okay, so yes, they often have the nausea and vomiting. Initially, they're in that much pain. That's kind of what goes on. Hi, Vivi. That cremasteric reflex, which is where you stroke your finger on the inner thigh next to the scrotum, and you should see that scrotum, if it's normal, it should kind of, you know, pull up. But you will not see that with testicular torsion. The affected testicle is elevated. It's usually kind of pulled up a little bit, because what happens in testicular torsion is there's a 720-degree rotation of the testicle, and so as you kind of rotate it up, it gets shorter, right? Think about just a normal rope that you would twist. It gets shorter if you twist it. Oh yeah, Glenda, those negative stem questions get you. And I'll be straight, like there are so many negative stem questions on the boards. You had to constantly reread the question like several times to really figure out what it was asking for. So make sure you pay attention to your negative stem versus your positive stem. All right. Your next question, a 22-year-old man presents to the urgent care clinic with burns caused by a hot oil spill while frying food. He denies facial involvement, dyspnea, or weakness. During the physical exam, the nurse practitioner noticed bright red skin with numerous bulla on the right arm and hand, bright red skin on the right thigh and right lower leg. On a pain scale of 1 to 10, he reports the pain is 8. Based on the rule of nines, what is the total body surface area of this patient's burns? Okay, so that was a ton of information, but the only thing we need then to answer the actual question, which is based on the rule of nines, what is the total body surface area of this patient's burns? So all that we need to go back through and identify in our question is what got burned. His right arm, right hand, right thigh, and right lower leg. So based on the rule of nines, what percentage of body area is burned? So we're going to try it without the options first to see if you can add those up in your head. And then we might try it with the options if we aren't close. Okay, so based on the rule of nines, what percent of his body is burned? Again, it says right hand, right arm, right thigh, and right lower leg. So based on rule of nines, what is his percentage of burns? Good. Yep. Valmora's got it right. Make sure you use, yep, good Naomi, good VB, good. Make sure you use the simplified version, not the one that splits up every single body part. Okay. Good, so the answer would be 27. One arm is 9, one leg is 18, so 9 plus 18 would give us 27. That's the simplified version. There is a much more complex version where it breaks it down to like this side is 1.5, this side is 1.5, this is 4. Like so boards, like based on the questions that I've seen, they're using the simplified version where it's just like, okay, one arm is 9, one arm is 9. The trunk is 18, the leg is 18, the other leg is 18, the head is 9. But yeah, you can split it down a lot more, but that's the schema for estimation. That's not the rule of nines. So that's why you would make it 27 instead of 19. Okay. All right, what is the significance of a positive Lockman sign? What is the significance of a positive Lockman sign? So pause in your mind, think of what Lockman is. What body part do we do that to? Okay. All right. A, instability of the knee caused by damage to the ACL of the knee. PCL, laxity, which may cause locking of the knee. Achilles tendon rupture. Patellar tendon rupture. What is the significance of a positive Lockman sign? A, instability of the knee caused by damage to the ACL, PCL, laxity, which may cause locking of the knee, Achilles tendon rupture, or patellar tendon rupture. Good, 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 good. Yep, I think everyone's got it right so far. Yep. Good job. Yep, everybody got that one right. Definitely. Yep, good. Lockman sign is about the ACL. Lockman sign is about the ACL. All right. A positive Chvostek sign is associated with. A positive Chvostek sign is associated with hypocalcemia, B, hypernatremia, C, hypokalemia, or D, hyperkalemia. I'll type down that spelling there too. Chvosteks. So we're looking for, what does a positive Chvostek sign mean? Hypocalcemia, hypernatremia, hypokalemia, hyperkalemia. Yep. Excellent, excellent, excellent. Good. All right, yep, the few that have answered are right so far. Not hyper, Rebecca, not hyper. It's hypo. Yep, good job, guys. So the answer is hypocalcemia. That's the sign that where they tap the cheek and it twitches upwards here. It's because of low calcium, and calcium helps with, neuromuscular things in the body. So hypocalcemia. All right, which of the following drugs that are used to treat ADHD is not classified as an amphetamine or stimulant? Which of the following drugs that are used to treat ADHD is not classified as an amphetamine or stimulant? So that's one of those negative stim questions, all right? So A, dexylmethylphenidate, which is Focalin. B, mixed salts of amphetamine, which is Adderall. C, methylphenidate, which is Ritalin. Or D, atomoxetine, which is Strattera. So which of those is not classified as an amphetamine or stimulant? Focalin, Adderall, Ritalin, or Strattera? Good. Try again, Marion. Good. Dorothy, good. Michelle. Good. All right. Excellent. So most people picked D, Strattera. So if we look at A, B, and C, all of them have the stem meth in it. So we know that they are a methamphetamine. Okay? So the only one that didn't was the atomoxetine, which is the Strattera. Focalin is just like a stem of methylphenidate. So anytime you have like a base word of a drug that's like methylphenidate and there's something on the front of it that's like dex, it means that they've taken branches out of the medication to try to lessen the side effects. So Ritalin and Focalin are the same medicine. Focalin would just in theory have less side effects. All right. A 25-year-old man with schizophrenia comes in for a routine annual physical. He is a heavy smoker and has a BMI of 28. The patient has been on olanzapine or Zyprexa for 10 years. Regarding the patient's prescription, which of the following laboratory tests is recommended for monitoring the adverse effects of atypical antipsychotics? Okay, so we got a lot of information here. It gives us his age, his background, how much he weighs, how long he's been taking it. But then the question doesn't even really ask us anything about his history specifically. It just says, what lab work should you be doing if a patient is on an atypical antipsychotic? Okay, so I can work with that. All right. So now we need to think about what happens with atypical antipsychotics. What are the side effects? What do they do? All right. So then we look at our options. A, fasting blood glucose, fasting lipid profile, and weight. B, urinalysis, serum creatinine, and a 24-hour urine for protein and creatinine clearance. C, liver function tests only. D, CBC with differential liver function test and weight. So which of those should we do if a patient is on atypical antipsychotics? First one was fasting blood glucose, fasting lipid profile and weight. B was UA, serum creatinine, 24-hour urine. C was LFTs. D was CBC, LFTs, and weight. Good. Good, Balmorris and Cindy. Let me grab my glasses. Okay. Yep, good. Vivi, good. Michelle. Try again. Rebecca. Good. Dorothy. Good, Naomi. Yep, so you want to pick A here. You want to pick their fasting blood glucose, fasting lipid profile, and weight, because they often get like a dysmetabolic syndrome related to antipsychotic use, especially after using it for so long. That's probably why his BMI is creeping up a little bit. It's not good that he smokes. So we want to look at his sugars, his lipids, and his weight, because he's at risk for things related to kind of like a dysmetabolic type thing. Okay. A 74-year-old man presents with recurrent abdominal cramping and pain associated with diarrhea that occurs from 4 to 5 times per day. He reports that he currently is having an exacerbation. The stools are bloody with mucus and pus. The patient reports that he has lost weight and is always fatigued. The patient denies recent travel or outdoor camping. Which of the following conditions is most likely? A, giardiasis. B, irritable bowel syndrome. C, diverticulitis. Or D, ulcerative colitis. Which of the following is most likely? He's having 4 to 5 stools a day that have mucus and pus. He's lost weight. He is tired. He has not traveled or camped outside. Does he have A, giardiasis, B, irritable bowel syndrome, C, diverticulitis, or D, ulcerative colitis? Good. Good, Cindy. Good, Miranda. Good, Balmorris. Good, Kenyatta. Good, Glenda. Good, Vivi. Good, Rebecca. Good, Michelle. Good, Naomi. Yep, got it. Excellent. So we all picked ulcerative colitis. The big tips here is the mucus and pus, and that's usually seen with ulcerative colitis. He also has lost weight because they're not absorbing anything, because the stool goes through their intestines so quickly. They don't have time to do their job. They don't get all the nutrients absorbed like they should. And he hasn't been outside. Outdoor camping can be associated with like maybe the giardiasis, because he would have been maybe drinking water that wasn't, as clean as it should have been. Plus he has remissions and exacerbations. So everything there kind of points you more towards ulcerative colitis than the other options there. Irritable bowel syndrome, you wouldn't see like the mucus and pus or blood with the IBS. Okay. All right, during the physical exam of a 60-year-old adult, the nurse practitioner performs an abdominal exam. The nurse practitioner is checking the left upper quadrant of the abdomen. During percussion, an area of dullness is noted beneath the left lower rib cage. Which of the following is a true statement regarding the spleen? Okay, so again, they give us this big long scenario, and then the question itself just asks us, pick which one of the following is a true statement about the spleen in general. So that whole scenario is pretty much useless. All right, A, the spleen is not palpable in the majority of healthy adults. B, the spleen is 8 to 10 centimeters in the left mid-axillary line on its longest axis. C, the spleen is 2 to 6 centimeters between the 9th and 11th rib on the left mid-axillary line. The splenic size varies depending on the patient's gender. Which of those is a true statement regarding the spleen? Spleen is not palpable in adults. It's 8 to 10 centimeters. It's 2 to 6 centimeters between 9th and 11th rib. or size varies depending on gender. Which one of those is true about the spleen? Yes, good, Valmoris. Good, Dorothy. Good, Rebecca. Yep. Good, Michelle. Excellent. Okay. Good, 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 good. Yep. So A is true. The spleen is not palpable in the majority of healthy adults. I think it's called the rule of odds that you can use to describe the spleen. It's 1 by 3 by 5 centimeters, 7 to 9 ounces in weight between the let's see, what 1, 3, 5, 7, 9, 5, 7, 9, and at the 11th rib. Is that it? 1 by 3 by 5 centimeters, 7 to 9 ounces, 11th rib. Someone confirm that for me. Who's familiar with the rule of odds? And I'm going to type it in until I'm sure. That sounds right. There we go. So it's kind of what you can use to describe the spleen there. Someone correct me if I'm wrong on that, okay? And that's what I think I remember learning in school. All right. When a domestic dog is suspected of being infected with the rabies virus, it can either be killed for a brain biopsy or it can be quarantined. What is the minimum number of days a dog suspected of rabies must be quarantined? What is the minimum number of days a dog suspected of rabies must be quarantined? I'll forego giving you guys the options now just to see what you guys know. How many days does a dog suspected of rabies have to be quarantined? Give me your best bets. Good. Good. I see a couple of right ones. Good. All right. Valmoris, Marion, and Miranda got it. Yeah, we're kind of split between two things. We got 10 days, and some people are also guessing 21 days. I see we got somewhere between 10 and 21 days. The general rule is it's a 10-day quarantine. It's a 10-day quarantine. Okay, so after 10 days, you can know if the dog has rabies, which will let you definitively kind of decide whether or not your patient who got bit by a dog has the rabies or not, or could have rabies. So 10 days. All right. Next one. Thiazide diuretics have been shown to have a beneficial effect on the bones, making them a desirable treatment option in hypertensive women with osteopenia or osteoporosis. What is the mechanism of action for their effect on the bones? All right, thiazide diuretics. What is their mechanism of action for their effect on the bones? A, they decrease calcium excretion by the kidneys and stimulate osteoclast production. B, increase both calcium and magnesium retention by the kidneys. C, increase bone mineral density. Or D, influence electrolyte excretion by the kidneys. A, decrease calcium excretion by the kidneys and stimulate osteoclasts. B, increase calcium and magnesium retention in the kidneys. C, increase bone mineral density. D, thiazide diuretics influence electrolyte excretion by the kidneys. What do we think? Yep, good, Michelle. Good, Marion. Good, Damarez. Yep, excellent, Glenda and Dorothy and Naomi. Good job. Oh, hi, Roxana. Good to see you. All right, all my answers seem to be in. All right, yes, the answer to that one is A. Thiazides hold on to their calcium, and it stimulates the osteoclasts, which helps us out with our bones. All right, 536. If you're following along in leak. A 30-year-old man with a history of gout is walking to the examination room, and the nurse practitioner notices that he is limping. When the patient sits down, the nurse practitioner notes that the metatarsophalangeal joint of the great toe is very swollen and is bright red. The patient reports that he attended a party the night before and had one too many drinks. He requests a prescription to treat his painful toe. The nurse practitioner prescribes indomethacin, 50 milligrams, TID, PRN, and colchicine for the patient. Regarding colchicine, which of the following instructions is correct? So we're going to, again, scenario is not exactly important. All we need to know is patient's got gout. We're going to give him colchicine, and we need to tell him how to take the colchicine, because there's a very specific way that they take it, and it's kind of funky. Okay. Take one pill every 1 to 2 hours until relief is obtained or the adverse GI effects occur, such as abdominal pain, nausea, or diarrhea. B, take one pill every hour until relief is obtained up to 24 hours. C, take one pill every 4 to 6 hours until the pain is relieved. D, take 2 to 3 pills, QID, until relief is obtained or adverse GI effects occur, such as abdominal pain, nausea, or diarrhea. So how do we take our colchicine? A, 1 to 2 until relief or GI. B, 1 pill every hour until relief, up to 24 hours. C, 1 pill every 4 to 6 until pain is relieved. Or D, 2 to 3 pills 4 times a day until relief or GI side effects. How do we give our colchicine? Let's see what we got. I did a lot of rotations in urgent care in school, so I was very familiar with colchicine, because that's where they always end up. Not yet. No one's gotten it yet. Nope. Yes, Glenda. No. So far, only Glenda's got it. Okay. So colchicine is funky. Okay. So they take 1 pill every 1 to 2 hours until relief is obtained, or they have GI side effects such as abdominal pain, nausea, or diarrhea. It's usually up to like 12 pills before they should stop it. Usually they have relief within like 12 to 24 hours, and then their symptoms are completely gone at 48 hours. So that's kind of management of gout. So this was his first ever occurrence of having gout. You would do the indomethacin and the colchicine. You could also possibly do steroids if they couldn't take the indomethacin for some reason, like they had an ulcer. So again, colchicine, when we're giving it to them, we tell them to take 1 tablet every 1 to 2 hours until the pain is gone or the diarrhea is so bad. I had one of my pharmacology students look at me the other day and he said, "Oh yeah, I always remember that because colchicine and crap go together." And I just had to laugh at that. It was so funny. But you can't forget it. All right, so after that, if they had a couple of exacerbations, so we usually don't start allopurinol on the very first time they get it. You want them to have a couple of like gout attacks, and then we're like, okay, you've had so many attacks, we can start you on the allopurinol, which is a daily pill for them to take if they're on gout, if they have gout, and it should try to prevent them. If they do have an exacerbation while on the allopurinol, they stop the allopurinol while they're having their exacerbation, take the colchicine, and then they wait until the pain is gone and they restart their allopurinol like that way. So that's kind of general management of gout. Okay, let's see. All right, which of the following individuals is more likely to be affected by alpha thalassemia anemia? A 53-year-old Greek patient, a 25-year-old Chinese patient, a 62-year-old Russian patient, or a 38-year-old African-American patient? Which of the following is most likely to be affected by alpha thalassemia anemia? Greek, Chinese, Russian, or African American? Because age is not exactly super significant there. We're talking about alpha thalassemia. It's related to a certain ethnic group. Is it Greek, Chinese, Russian, or African American? No, Vamores, I must not have seen it, but if you got it correct, right on. Good, good, good. Yep. Yep, yep. Everyone's gotten that one right. Excellent. Excellent, excellent, excellent. Okay. Yep, so alpha thalassemia minor is prevalent among Asians such as Chinese or Filipinos. Beta thalassemia, which one is that one more common in? Beta thalassemia, which one is that more common in? Of those four, Greek, Chinese, Russian, or African American? Beta thalassemia, Greek, Chinese, Russian, or African American? Good, good, Vamores. Good, Cindy, good, Roxana. Good. Good. So alpha goes with Asian, A, alpha goes with Asian, and then beta thalassemia is just the other one, and that is Mediterranean areas such as like Greece or Italy, those areas. So those people will be more likely to get the beta thalassemia. Excellent. All right. What is the most common cause of infertility among women in the United States? A, fallopian tube scarring due to PID. B, ovulation disorders. C, age older than 35. Or D, endometriosis. Which of those is the most common cause of infertility? Fallopian tube scarring due to PID, ovulation disorders, age older than 35, or endometriosis. Good. Good, Cindy. Good, Memorize. Good, Roxana. Good, Rebecca. Good, Miranda. Yep, good, Vivi. Good, Marianne. Yep. Well, Rebecca. Try again, Rebecca. Good, Dorothy. Yep, good. So yeah, it's ovulation disorders, and that's typically related to things like polycystic ovarian syndrome, which is very common. So that one says, according to the book, it says 25%. The second most common cause is endometriosis. About 15% of women with difficulties getting pregnant, it's related to endometriosis. Again, polycystic is one of the most common causes. Infertility in men, however, is actually related to something like a varicocele, or if they have an abnormal or low sperm count. Those are the reasons that men have issues with infertility. Varicocele or abnormal or low sperm count. The varicocele causes the testes to become warm, and that heat can kill the sperm. Okay. All right. A 65-year-old man presents to the clinic complaining of random recurrent episodes of dizziness with nausea. The patient describes it as a sensation of the room moving or the room spinning. It is worsened by sudden head movement. During the episodes, he becomes very nauseated. He also has tinnitus with hearing loss in his right ear. The patient has type 2 diabetes, is in on a prescription for metformin and an ACE-I. Blood glucose at his visit is 80. Which of the following conditions is most likely occurring? A, vasovagal presyncopal episode. B, Meniere's disease. C, atypical migraine. Or D, hypoglycemia. So let's review our patient. He's 65, dizziness, room is spinning, worse with head movement, very nauseous, tinnitus, hearing loss in one ear, has type 2 diabetes on metformin and an ACE-I, blood glucose is 80. So is he having a vasovagal presyncopal episode, B, Meniere's disease, C, atypical migraines, or D, hypoglycemia? Excellent. Yep, y'all caught that one right away. So this guy definitely has Meniere's disease. He's got the classic triad of symptoms: episodic, tinnitus, and hearing loss. Okay. The other thing that I was thinking, like before I saw the hearing loss, was like BPPV, which is the one where if you move their head, they get dizzy like that. But since he has the hearing loss, that really differentiated it in my mind to Meniere's disease, because he does have the classic triad then: dizziness, tinnitus, and hearing loss. All right. Okay. Next one. All right. Boards like these kinds of questions here too. All of the following physiological changes are present in the lungs of the elderly except. So it's like there's a lot of questions like when we talk about like geriatric section where it talks about like what is normal for older adults to have changes in and what is not normal for older adults to have changes in. And they want you to be able to identify between the two, like what's normal for them to like, okay, yeah, so they might lose a few inches because of spinal compression. But you know, this is not normal, or this is. So learning those differences are important. Okay, so all the physiological changes are present in the lungs of the elderly except decreased forced expiratory volume, slightly increased residual volume, C, increased lung compliance, or D, earlier airway collapse with shallower breathing. So what of these changes do occur, and then which one of those does not? All right, so we're looking for which one of those does not occur. Decreased forced expiratory volume, slightly increased residual volume, increased lung compliance, early airway collapse with shallow breathing. Good, Valmeriz. Good. Yep, good, Marion. Good, Vivi. Another test taking tip I would say on these types of questions, when it's looking for an accept, often the answer that you pick will be opposite of something that's correct. So like how everyone picked increased lung compliance on this question, you actually would see decreased lung compliance in the older person. So usually when you look at the 4 answers, three of them will obviously occur, and the 4th one will be the opposite of something that should occur, that you would expect. So like you would normally expect decreased lung compliance, the opposite of that is increased lung compliance. And that is such a theme across 4 questions. The 4th thing is usually not something off the wall. It's something that's opposite of something you'd normally see, and that's where you get your negative stem from. That's where you pick your question, pick your answer from. It's something opposite of what would normally occur. Does that make sense? Okay. All right. A 50-year-old woman of Irish descent presents with history of lethargy, feeling weak, nausea, anorexia with diarrhea, and abdominal pain. The woman's skin appears tanned, but she denied prolonged sun exposure. During physical exam, the nurse practitioner notes hyperpigmentation of the nipple area, the gums, and the lips. The electrolyte panel reveals hyperkalemia and hyponatremia. She reports craving salty food. Which of the following is most likely? So this one is a question where the entire scenario is actually important because it's asking us to diagnose the patient. So this would fall under that domain. Remember, there's 4 domains on the boards, and one of them is to diagnose properly. So does this patient have Addison's disease, B, Cushing's disease, C, metabolic syndrome, or D, a cutaneous drug reaction? So again, she is lethargic, weak, nausea, poor appetite, diarrhea, abdominal pain, tanned, high potassium, low salt, and is craving salt. What does she have? Addison's, Cushing's, metabolic, or cutaneous? Yep. Great. Cheryl, good. Miranda, Marion, Roxana, Vivi, Glenda, Dorothy. All right. Correct. So this is Addison's. So Addison's disease is also like primary adrenal insufficiency. So the adrenal glands do 3 things: sugar, sex, and salt. So salt is one of those things, the mineral corticoids. So whenever I think of Addison's, I think we need to add some salt. So the patient has hyponatremia and she's craving the salty food to try to make up for that, what she's losing. So that's how I can kind of differentiate that. Also with the Addison's disease, they get that tanned look. We do want to try to catch this early because it can cause an Addisonian crisis. It can mess with their blood pressure as well. If they have low salt, they'll usually be dehydrated because, you know, water follows salt. So if we're losing the salt, we're going to lose the water. So that's where she's kind of getting that lethargy and weakness from too. Okay, so she's just got a slew of things going on there that you need to think about. All right, let's see what we got next. Trying to skip the non-clinical questions. Let's see. All right, which of the following pharmacological agents is the best choice for an elderly patient with insomnia? A, diazepam, which is Valium. B, zolpidem, which is Ambien. C, temazepam, which is Restoril. Or D, diphenhydramine, which is Benadryl. All right, which one of those is the best sleep agent for older adults? Diazepam, which is Valium. Zolpidem, which is Ambien. C, temazepam, which is Restoril. Or D, diphenhydramine, which is Benadryl. Which one is best? Good, Cheryl. Yep. Good, Glenda. Good, Valmarez. Good, Roxana. Good, Dorothy. Good, Marion. Good, Michelle. Y'all got it. Yep, so we're going to use the Ambien. It's got a quick onset. It works in about 15 minutes. It's got a very short half-life, so it's going to metabolize out quickly, which we definitely want to do that in our older adults because their livers have slowed down, so their metabolism and excretion is slower. Medicines hang out longer in their bodies. Of course, we're going to want to avoid the Benadryl because of all those anticholinergic side effects with the dry mouth and the confusion, and they often will get a prolonged sedation, which is kind of opposite of what we're going for. We just want them to be able to go to sleep. Diazepam and temazepam both have really long half-lives. Since, again, that they're slower at metabolizing, they would hold on to those medicines much longer and put themselves at risk for, you know, respiratory depression or too much drowsiness, not being able to wake up in the morning. So we want to use the Ambien for them. Okay. A 22-year-old woman is going on a 5-day cruise for her honeymoon. She reports a history of severe motion sickness. Well, honey, I wouldn't have recommended going on a cruise. Which of the following medicines can be prescribed for motion sickness? All right. We're going to give the patient, are we going to give them Dramamine, Reglan, Zofran, or scopolamine patch? Which of the following medicines can be prescribed for motion sickness? Dramamine, Reglan, Zofran, or scopolamine patch to help this poor woman with her seasickness. What shall we give her? Good, Cheryl. Good, Miranda. Yep, good, Roxana. Good, Glenda. Yep. Yeah, we're getting some varying answers. We're getting some varying answers there. The trick here is it's asking for a prescription. What prescription drug can we use? That's why it says at the end, it says, which of the following medicines can be prescribed, not just recommended. So the prescription one would then be the scopolamine patch. Good job, most of you picked D. Okay, because so that can be used, it's just a small patch, it's put behind the ear, lasts for 3 days, so she really only needs 2 of them. So that's great. Just make sure you also advise the patient that it needs to go on 4 hours before they get on the boat, or it's not really effective. They can't step on the boat and stick it on. They need to put it on like 4 hours before they get on the boat. Okay? Dramamine would help, but it's over the counter, so it is not a prescription medication. And then, of course, Zofran is more for cancer-related nausea and vomiting, post-operative, alongside narcotics, things like that. Okay. Okay. Multiple myeloma is a malignancy of the White blood cells, red blood cells, plasma cells, or platelets. Multiple myeloma is a malignancy of the white blood cells, red blood cells, plasma cells, or platelets. Multiple myeloma. White blood cells, red blood cells, plasma, or platelets. Good, Ramirez. Good, Vivi. Good, Glenda. Yep. Good, Marion. Try again, Michelle. Good, Miranda. Good, Roxana. Good job, guys. Yeah. So multiple myeloma messes with the plasma cells. So that's our a lot of our B cells or lymphocytes, and therefore that also affects the bone marrow. So signs and symptoms you'd see with that are things like bone pain. So a lot of times anyone has one of those cancers that's messing with the bone marrow. It's very painful in the bone itself. Sometimes they could have like fractures. A lot of times they'll have anemia, and then they'll have the depressed immunity. So it really messes with everything that the bone marrow produces, which is our red blood cells, our white blood cells, all of that. So you'll see effects from all of those things. So you'd see the depressed immunity because of the low white blood cell count. You see the anemia because of the red blood cell count. So multiple myeloma has major effects on the body for those reasons, because it does mess with the bone marrow. That's similar to the kind of thing you see when you're giving your patient an immunosuppressant for any reason, is that it can mess with their bone marrow. And you're giving them chemotherapy, it messes with bone marrow because that's one of the fast growing cells in the body that chemotherapy can't be selective against targeting. Okay. All right, a 76-year-old woman reports for the previous 4 months she has noted severe stiffness and aching in her neck and both shoulders and hips that is worsened by movement. She reports having a difficult time getting out of bed because of the severe stiffness and pain. It is difficult for her to put on a jacket or blouse or to fasten her bra. Along with these symptoms, she also has a low-grade fever, fatigue, loss of appetite, and weight loss. Starting yesterday, the vision in her right eye has progressively worsened. She has annual eye exams and denies that she has glaucoma. Which of the following conditions is most likely? All right, so again, this falls under our diagnosis domain, so the whole entire paragraph will be significant in us finding our diagnosis. So we've got stiffness in neck, shoulders, hips, worsens with movement, hard time getting out of bed because it's painful, low-grade fever, fatigue, loss of appetite, weight loss, vision loss in right eye. So which of the following conditions is most likely? RA, degenerative joint disease, polymyalgia rheumatica, or fibromyalgia? RA, DJD, PMR, or fibro? What do we suspect in this patient? Good. So think about what kind of gives it away. Try again, Glenda. What kind of gave it away for you? Okay. Yeah, the correct answer for this one is C, the polymyalgia rheumatica. So it really kind of sounds, it can kind of sound like RA, almost, because you're like, okay, we have joint pain, we're older, but then again, okay, she's 76. All right, RA usually happens a lot earlier in life. Their diagnosis is usually earlier. So, okay, maybe I can rule that one out. Plus, this eye loss vision thing, that's not really related to RA, so I can still kind of rule that one out. DJD, that wouldn't mess with her vision either. And fibromyalgia is more related to pain, not to joint stiffness. So I'm left with polymyalgia rheumatica. And if I remember something about PMR, about 15 to 30% of those patients will get giant cell arteritis or temporal arteritis because polymyalgia rheumatica affects both the joints and the arteries. So we see a high incidence of them having the temporal arteritis, which causes vision loss in one eye. The patient will need to see a rheumatologist. They'll need to be put on steroids so they can restore vision to the eye and prevent permanent vision loss. Okay. And yes, Mary, good point. The shoulders and hips are very often affected by polymyalgia rheumatica. So. All right, let's see. The nurse practitioner orders an ankle brachial index test for a patient, or ABI. Which of the following disorders is the ABI test used for? Venous insufficiency, osteoarthritis of the arm or ankle, peripheral artery disease, rheumatoid arthritis. ABI used for what? Venous insufficiency, osteoarthritis, peripheral artery disease, or rheumatoid arthritis. Good, Marianne. Yep, good, Roxana. Good, Miranda. Excellent. Yep, good, Bomarez. Good, Glenda. Good. Oh, hi, Tanya. Good, Tanya. Yep, Rebecca, you got it for sure. Yep, so we're going to use this for peripheral artery disease. It helps us to decide how severe the blockages in the lower extremities are based on like how different the systolics are, and then it's calculated out. So an ABI score of 1 to 1.4 is normal. Anything less than 1 is abnormal, and anything less than 0.5 is severe. So again, that's calculated based off of the blood pressures and the systolic pressures. Ankle brachial index. All right. Let's do one more question, and then we'll wrap it up. Okay. Let's find a good one. Oh, let's do this. All right. A male 16-year-old with a recent history of a cat bite is brought to the walk-in clinic by his mother. The bite occurred about 2 hours before the visit. The nurse practitioner evaluates the wounds and notes 2 small puncture wounds. There is no redness or purulent drainage. The mother reports the teenager received a tetanus booster when he was 12. Which of the following is the correct action to take? All right, so let's review the scenario again, because I like to review it twice before I'm jumping in to try to find my answer. 16-year-old cat bite 2 hours ago. We see it. There is no redness or drainage. He's recently had a tetanus booster 4 years ago. What should we do? A, clean the wound with soap and water and apply a topical antibiotic and a bandage. B, because the wound is clean and does not appear infected, there is no need for antibiotics. C, give the patient a tetanus booster for the Tdap form of the vaccine. D, clean the wound with soap and water and prescribe Augmentin 500 milligrams by mouth BID times 10 days. What is the correct thing to do with a cat bite? A is clean with topical antibiotics. B is it looks clean, doesn't appear affected, don't give antibiotics. C, give him a tetanus booster. D, clean and give Augmentin. What should we do? Excellent. Good job. Everyone's got it. Good. Good. Excellent. Good. Yeah, everyone picked D, to clean the wound with soap and water and prescribe the Augmentin. The patient doesn't need the tetanus booster because it's been within the last 5 years. So if it had been greater than 5 years, they would have needed a booster, a tetanus booster. Okay, so again, you always clean it. You always do the wound care. Cat bites, about 80% of those get infected with either Pasteurella, sometimes it's staph. So we use the Augmentin every time. With dog bites, it's a much lower percentage. Varying resources will say different things, but it's somewhere between 5 and 15% of dog bites get infected. So dog bites, actually, you can wait and watch with a lot of those, but cat bites, just because of the bacteria that lives in their mouths, you always go straight for it with the cat bites. All right, well, that wraps up our lightning round for the day. If you are new to my page, welcome. I'm glad to have had you today. Make sure you like my page so that you can see future updates for lightning rounds. And then I also do some paid reviews. So if you're interested in doing one-on-one tutoring, I'm going to have a lot of spots come open in December. I'm working with a few students right now, and I'll be finishing up with some of them towards the end of November. So during December, I'll have a lot of spots open up for one-on-one tutoring. I'll be able to be very intensive during that time. If you're preparing to take your boards, you're graduating in December and you're preparing to take your boards in January. So with the one-on-one tutoring, I do a lot of different things. So I can, I can go through system reviews with you. I can try to help you with test taking skills, or if you have testing anxiety. I've helped counsel people with those types of things. We can do practice questions together just like here, but I do them to where they're actually on the screen so you don't have to listen to me read. It can be a little bit more helpful. If you have any issues with a specific system, I've got some videos recorded. I'll have a lot of time off in December, so I'll be able to record several more systems and put those out there for purchase. I'll be launching my website at the end of the month. It's going to make downloading my videos a lot easier, and it's going to have all of my lightning rounds that I've done here on Facebook saved to it, so you'll be able to watch all of them in one place on that website as soon as I get that up. All right? So send me a message if you have any questions about cost, about sessions, about my reviews. So just send me a message on my Facebook page, and I'll get back with you as soon as possible. So I'll see you guys next time. Bye.